Welcome back to Thrani, I'm Joe B. Today I'll show you how to correct a lumbar ERSL dysfunction. Let's dive in. A lumbar ERSL is when a singular or multiple vertebrae of the lumbar spine get stuck in extension, rotation, and side bending to the left. When it is multiple vertebrae, it is called a stacked ERSL. To treat a lumbar ERSL, position your patient in left side lying first with the rest of her joints above the spot you want to mobilize to all be side bent and rotated to the right side. As you can see, the upper torso above the L4 is side bent to the right and rotated to the right. You will then be in front of the patient with your right forearm leaning against the right anterior shoulder while the left hand pulls the ilium to the left to get the patient to tolerable end range first and take up the slack. Once there, use the patient's muscle guarding by having her rotate to the left against your resistance and hold it for 6 to 7 seconds. This will cause her muscles to contract, and following the principle of autogenic inhibition, any muscle contracting will have an equal relaxation phase afterwards. Kind of like the law of physics, that in any action there will be an equal and opposite reaction. This will allow you to rotate her trunk to the right further to gain more range and repeat 3 to 5 reps. After like 1 to 2 sessions of this, and once you've started gaining your patient's understanding and trust, then by the 3rd and 4th sessions, you can progress to non-thrust mobilization technique. Position the patient and yourself the same and take her trunk to mid-range rotation by taking up the slack as tolerated for grade 2 mobilization. Once you get your patient to grade 2 mobilization range, you can already provide joint oscillations there for 30 reps. You ask the patient to breathe, and during the exhalation phase, you rotate further as tolerated to get to grade 3 mobilization or up to the limit of the range. You can hold this particular position for 30 seconds. After that, ask the patient to breathe one more time, and during that exhalation phase, take her trunk to grade 4 mobilization range or at the limit of the range and hold for another 30 seconds. You can even provide oscillation for 30 reps as you get to either grade 3 or 4 ranges, as that can optimize your patient's pain relief. During the non-thrust mobilization phase, do observe your patient's muscle guarding, because if it is worsening, then it's probably better to revert back to muscle energy techniques. But if the muscle guarding is getting better, then you can go ahead and progress further into grade 3 or 4 of the mobilization range and eventually to thrust techniques. By the 5th and 6th sessions and onwards, then you can advance to high velocity, low amplitude thrust or thrust manipulation, or also called thrust articulation. Position the patient and yourself the same and take her trunk to grade 4 mobilization or at the limit of the range. From there, you can deliver a high velocity, low amplitude thrust or a quick end range thrust. With this technique, you may feel a pop in her spine or a joint cavitation. A cavitation is basically when the nitrogen inside the joint comes out of the joint, resulting to a matter change from liquid to gas, represented by a popping sound. There you have it. To elevate your mobilization skills and have better patient satisfaction or outcomes, you have to think muscle energy techniques first, then non-thrust mobilization, then high velocity, low amplitude thrust manipulations. For the exercises, repetitive seated or standing lumbar flexion, right side bending and right rotation active range of motion exercise can be performed for 2 to 3 sets of 10 reps. This can be progressed by adding 15 to 30-second hold times for stretching. A post-treatment seated flexion test can be done to reassess the asymmetry and then transition as you see fit. The assessment for ERSL in this animation, we will assume that it is the L3 that is stuck in ERSL. There are 2 types of tests that determine lumbar asymmetry: the seated lumbar flexion test and the seated lumbar extension test. Since your patient is stuck on L3 ERSL, then to make that vertebrae stick out, you need to select the seated lumbar flexion test. Patient is in short sitting position, feet flat on the floor and arms across shoulders. The therapist will be behind the patient. The iliac crest will be palpated first by the web space of the therapist's hands. Then the dominant hand thumb will reach across to arrive at the L4 spinous process. From there, the thumb goes down to the inferior spinous process, which will be the L5. Afterwards, the thumbs move 2 finger breadths laterally to arrive at the transverse process, which will be the major landmark to palpate to determine the presence of ERSL or ERSR. The patient is then asked to slouch for lumbar flexion. When doing the assessment, always start by palpating the L5, then go superiorly until you arrive at the L3, and then finish all the lumbar vertebrae. Normal findings are that all the lumbar vertebrae transverse processes should move backwards or become more palpable. Abnormal findings to confirm the presence of a L5 ERSL or an L3 ERSL is that the left transverse process will become more prominent during seated lumbar flexion, since L3 right-sided facets are stuck downward and forward. If it is stuck towards L5 or L3 ERSR, then the right transverse process will become more prominent, since the left-sided facets are stuck down and forward during the seated lumbar flexion test. The cause of this can be due to tightness of the ipsilateral multifidus muscle, likely from a job that requires repetitive extension, side bending, and rotation to the left. Trauma from a motor vehicular accident can also cause it. ERSL vertebrae can bring about a chronic localized dull aching pain on one side of the low back. There will also be limitation in motion patterns, specifically towards flexion, right side bending, and right rotation. Since the right lumbar rotation is necessary for adequate left, forward, and backward arm swing, as well as right lower extremity initial contact to loading response, these aspects will be limited if the vertebrae is stuck on ERSL. So do you want to know how to correct a lumbar FRSL dysfunction? If so, then hope this video helps you out. Thank you so much. If you like this video, please like, share, and comment. And for more therapy animations, please subscribe to Therani.